Hi everybody, thanks so much for joining us today for our next webinar, which is Identify and Understand Substance Use Coercion for AOD Clinicians. Before we begin, I do want to acknowledge that this webinar is on Aboriginal land, the land of the Wurundjeri people of the Kulin Nation, and we'd like to pay respects to any Aboriginal people who are with us today. So my name is Sheridan and I am the facilitator of today's webinar, and we're very lucky that we've got three speakers with us today. We understand that this is a topic that it's quite a big topic, and we do kind of also believe that it is a topic that will need probably more clarification, and there will be, after today, we'll look at some of the feedback we get from you and some of the questions, and there will be workshops also being developed for early next year as well. So I did want to just kind of put that out there first, that it is such a big topic, we know, but also very, very important that we know that AOD clinicians are feeding back that they're dealing with this issue and want to know how to respond. So I'm very grateful that we have our three speakers with us today. I'm going to introduce them to you now. We have Steve Hurd, who is the Specialist Family Violence Advisor for Turning Point. Thanks so much for being here, Steve. And besides Steve, we have Mariah Roos, who is the Family Violence Capability Project Lead with VADA. Thanks so much for being here. And then beside her, we have Sue George, who's the Specialist Family Violence Advisor, AOD at Odyssey. Thanks so much for being with us today. So we don't normally get to have three, so we're really, really lucky today. So also, before we get started into the content of the webinar today, we do like these webinars to be really interactive. And we're really hoping you'll give us some feedback about this and interact and give us your questions as well, because we know it's a big topic. What you'll see on the screen now is some of the little icons that you'll notice are at the top of your screen. So you've got the little blue hand, which is if you want to ask a question. And part of my role today is to monitor those questions, and then I'll be fielding all the questions and comments, and then I'll be putting those questions to our presenters as well, and maybe participating as well in answering some of those questions. So you can go ahead and ask questions at any point, so using that little blue hand. And what I'll do is I'll just capture those. I've got an iPad in front of me that I'll keep a track of those. If you've got comments as well, please do put comments in those, in the little chat box as well. There's also downloads. So you'll find that there's a couple of pieces of research that are referenced today throughout the webinar. And what we've done is we've put those in the download folder for you. So the two pieces that we've included there's in the International Journal of Drug Policy, we've got the interplay between substance use and intimate partner violence perpetration, a meta-ethnography. And then we've also got a piece from the National Centre on Domestic Violence, Trauma and Mental Health. It's the coercion related to mental health and substance use in the context of intimate partner violence. That one is from the States, so when you download that and have a look at that, you might see some terminology that's slightly different, but they're very, very good tools, and they will be referenced today. So you can go ahead and download those now or any time during this webinar. If you're watching this as a replay, you won't have access to that, so you will just need to email one of us and we can send those through to you. As I said, we are looking at creating further workshops and trainings from this content today. So we'd really ask if you could stay with us till the end, and there's going to be a survey and feedback section that will come up at the end. And when that comes up, there's a survey, but also just give us your feedback on the kinds of things that you'd like to see more of. Also, if there's any kind of topics or speakers that you'd like to see us bring onto these webinars, give us that feedback there as well. So that'll happen at the end. So I might hand over to our first speaker now, to Stephen, and we'll get stuck into the content. Thanks so much, Stephen.
Yeah, thanks very much, Sheridan, and hello everyone. What I'll be doing is introducing the topic with an overview of what we mean by family violence and coercion. Mariah will then be drilling down into detail about relevant behaviours and talking about the substance use, power and control wheel. And Sue will be looking at practice implications when working with victim survivors. So collectively we'll be linking together theory, evidence and practice. During this presentation we'll be talking about family violence, and we understand it may trigger certain emotions in some people. So please be aware of this and take the necessary precautions to look after yourself and access your support network if you need to. We'll also be using language such as victim survivor in reference to people who have or are experiencing family violence on a day-to-day basis, and this includes children. We'll be using the term perpetrator for people who use family violence for the purpose of having power and control over another family member. We acknowledge too that family violence is gendered, where perpetrators are predominantly male and victim survivors are predominantly female in relation to intimate partner violence. We also know that Aboriginal peoples, LGBTIQ people, people with disabilities, people from CALD communities and their intersections experience specific risks and different forms of violence and may face further barriers based on gender inequality, victim blaming, along with multiple forms of stigma. We hope you've been able to watch the Family Violence and AOD webinar produced in the same series of webinars in July of last year, and that's called Identify and Respond to Domestic and Family Violence in the AOD sector. So that webinar provides an overview of the key areas of identifying family violence and undertaking safety planning with the client. If not, then please consider viewing it when you have some time. Our collective interest in this topic comes from wanting to elevate the visibility of perpetrators and describe how AOD use can be used strategically in a family violence context, looking beyond situational violence. This may then help us as AOD clinicians to develop more nuanced formulations about what is going on for our client, as well as speak to family violence risk. So just a few goals that we've come up with for today's presentation is simply firstly to define what we mean by substance use coercion, identify differences between perpetrator and victim survivor presentations, provide some practice guidance for AOD clinicians about how to respond, and for this particular presentation we'll be focusing on victim survivors. We want to identify some links with MARAM information sharing and child information sharing schemes for our Victorian context. We want to promote the use of debriefing, supervision, secondary consult to enhance family violence practice. But I guess overall we want to influence clinical practice to improve outcomes for our clients. Now I'd like to move on to some definitions about family violence and what we mean by substance use coercion. So for family violence, Section 5 of the Family Violence Protection Act in Victoria defines violence as behaviour towards a family member that is physically, emotionally, sexually, economically or psychologically abusive. It includes behaviour that is threatening, coercive, controlling and dominating. So the legal definition of family violence here in Victoria that you see on the slide identifies family violence as an ongoing experience of power and control. And there are certainly different relational contexts within which this occurs, such as intimate partner violence, elder abuse, adolescent violence in the home, between siblings and from adult children towards their parents. And this definition specifically states that children witnessing or experiencing the effects of family violence is family violence itself. And apart from the formal definitions, you may come across a range of statements describing family violence in a plain English kind of way. So I've put a few of these up on the slide, and there emerges a consistent theme that family violence is an ongoing pattern of coercion and control, instilling fear in the victim survivor. So just looking at these is a pattern of behaviour in which someone seeks power and control, causing others to feel threatened, worthless or fearful, is when someone behaves abusively towards a family member as part of a pattern of behaviour that controls or dominates a person, that causes them to fear for their own or others' safety, is a pattern of behaviour where one person tries to dominate and control the other, is a behaviour by a family member that creates fear and control over their partner, is a pattern of abusive and controlling behaviours within intimate relationships as well as between family members, and is rarely a one-off incident. So I've provided links there to those particular organisations just so you can understand their context a little bit better. So how prevalent is family violence within AOD sector in general? Well, over the next two slides I have some stats. Firstly, women's experience of family violence for those who have attended AOD services. And we see numbers like 40 to 80%, 67%, 31% and 90%, given different sets of criteria though. Now looking at men's use of violence, we see figures like 50 to 85, 40, 34, 90, again in a range of different contexts. So trying to summarise those, yeah, the figures vary significantly, the contexts vary a bit, the types of violence, as how it's measured, it varies. But I think what comes through and what is clear is that family violence is a common experience for people seeking AOD treatment. Two tools I'd like to bring our attention to, which you're probably already familiar with, are the Power and Control Wheel, firstly. This was created in the 1980s through the stories of hundreds of women who had experienced violence. Its themes are now part of our legal definition of family violence, which really does reflect a socio-cultural change in our understanding of what family violence is. It helps us to see that family violence is more than just physical violence, but a range of subversive behaviours associated with social isolation, financial abuse, emotional abuse, really based on attaining power and control. And the most severe forms of violence, namely physical and sexual abuse, exist on the outside of the wheel as they act as consequences if the other tactics fail to give the perpetrator what they want. And as you can see in the top left segment, coercion is one of the 8 themes represented, though there is significant overlap. And the second tool are the evidence-based risk factors around violence. And these have been identified through research or researching the experience of women who have been killed or almost killed by a current or former partner. And consequently, when one or more of these is present, in the risk of death for the woman is elevated. Among the list of perpetrator behaviours such as AOD use itself, jealousy, threats to kill the victim or children, threats of suicide, stalking, unemployment. Risk is also increased at times of pregnancy, new birth, and at recent separation. Further factors have been added through the Marram framework, relevant to us here in Victoria, highlighting the involvement of children in witnessing or intervening in the violence. In addition, Marram requires us to offer a family violence risk assessment when these factors are identified. And as you can appreciate, substance use coercion probably sits right across these particular risk factors. So moving on to the 2 references which we're using for the presentation that Sheridan mentioned earlier. Firstly is the toolkit, and that gives us a definition of coercion and substance use coercion, where coercion is the use of force or manipulation to control an intimate partner's thoughts, actions and behaviours to undermine and control an intimate partner. So as you can see, the definition really speaks to the use of controlling behaviours by a perpetrator to get what they want in much the same way that family violence is defined. With substance use coercion, they are abusive tactics targeted towards a partner's substance use as part of a broader pattern of abuse and control. So in the substance use coercion, it really is the victim's substance use is the target of the control. That toolkit was based on a survey conducted in 2012 from over 3,000 callers to a family violence hotline. And I've reproduced some stats which are in the toolkit as well for reference. But it says that 43% of those callers had experienced at least one form of substance use coercion, so many had multiple forms. And of the 15% who actually sought help for AOD, over half of them, 60% of them, said that the partner or ex-partner had tried to prevent them or discourage them from getting help. And further stats suggest that about a quarter of the callers had either experienced pressure to use, had used to reduce the pain of the violence they were experiencing. About a quarter were too afraid to call the police for help. And as the stats suggest, that they're not isolated, but individuals can experience a variety of those. And lastly, well over a third of callers said their partner or ex-partner had threatened to report their AOD use to authorities to stop them getting something they really wanted. And these typically revolve around trying to find safety for themselves and their children. The second resource we're using for the presentation is the work of Gilchrist and others from 2019, who undertook a systematic review into the relationship between intimate partner violence and AOD use. What they were able to do was to categorise attitudes and behaviours of perpetrators and survivors within intoxication and withdrawal phases of addiction, and also develop themes around the impact of relationships, power and control, psychological vulnerabilities, and the victim survivor's agency and resistance. At this stage, I just wish to highlight what they found about intoxication and withdrawal. So in the context of intoxication, both perpetrators and victim survivors viewed substances as disinhibiting the self, and that is, they turn you into another person, much like a Dr. Jekyll and Mr. Hyde situation. Further, perpetrators would blame the substance for their violent behaviour and attributing the violence to a sickness. They also view their violence as moderated and reasoned, whereas other studies show that violence, while intoxicated, is uncontrolled, brutal and more severe than when not affected. The perspective from a victim survivor, though, is that they view intoxication as part of a broader pattern of behaviour and anticipate a repetition of the violence. With respect to withdrawal, what this research found was that perpetrators have an expectation that their partner will obtain drugs or the money to buy the drugs. And if they don't get the drugs, the perpetrator will use further violence to gain compliance. There also exists a contradiction, as the perpetrator would on one hand expect the partners to obtain the drugs and then on the other demonstrate disgust and contempt towards them for being bad mothers, addicts, prostitutes. So within this risk environment, the victim survivor can develop a range of protective behaviours to protect herself and her children from ongoing violence. So now I'll pass over to Mariah to continue.
Yes, thank you, Stephen. So my name is Mariah, and in this part of the presentation I will bring together the different elements that Stephen introduced to further unpack the concept of substance use coercion and the impact on victim survivors. Understanding how substance use coercion works and why will have implications for our work with victim survivors. And that doesn't matter whether we work in an AOD setting or family violence support service or any other support system that's involved with this family. So throughout this presentation I will be using examples of substance use coercion strategies used by the perpetrator, and these examples come from the literature that Stephen just referred to, or from many stories that we've been hearing about from practice experience. This is not an exhaustive list of examples, but it serves to provide an insight into what substance use coercion might look like for our clients. When I think of the complexity, though, of family violence, and in particular of the intersection of family violence and substance use, I visualise a kaleidoscope because it can be really complex, it's multi-layered, it's interacting and constantly changing. So substance use can play a key role in this wider pattern of power and control mechanisms. So if we want to take a closer look at substance use coercion, it's useful maybe first to identify the different roles that substance use can play in the context of family violence. And Stephen identified earlier that victim survivors as well as perpetrators may hold different perspectives on the use of substance in the family. These perspectives are the underlying drivers of the roles that drug and alcohol can play in a family violence situation. So again, these are generalized concepts and can be different for each person. However, there are some really interesting patterns that emerge. So from the literature, I identified 4 different categories of these patterns and strategies. So the first one would be risk assessment and risk management by the victim survivor. The second one is also related to the victim survivor and very much is around coping strategies and survival mechanisms. The third one is more linked to the perpetrator and is about excusing and justifying violence. And the fourth one is its own subcategory, and that's the substance use coercion. So back to risk assessment and risk management. So if we're placing ourselves in the shoes of the victim survivor, the literature describes that the victim survivor has very sharp observation skills and is often really capable to anticipate and predict the type of violence as well as the intensity of the violence. And she may use particular strategies to manage the situation. So she knows that low mood is often related to increased violence, and so is intoxication, as Stephen just already explained. So victim survivors have described an increased sense, for example, of emotional closeness when the right amount of substance has been consumed. And in these scenarios, she might like to manage the quantity of substance used in an attempt to reach that just right balance and maintain this carefully. But like Stephen discussed, the level of intoxication can either be too low when the perpetrator goes into withdrawal or is too high. The victim survivor may attempt to manage the risk of escalation by controlling her partner's use, or in other scenarios we're also familiar with stories that the victim survivor might actually stimulate substance use and provide substances to her partner in order to, so he passes out before the violence can actually occur. So moving on, substance use may be used as part of a coping and survival mechanism developed by the victim survivor. So, for example, she might use alcohol or drugs to manage physical pain or to dull emotional pain of the trauma. Or she might be using to prepare for what is to come. Now, and although these coping strategies might be very effective in the short term, in the longer term they may have a negative flow-on effect that increase the risk of future violence because she is now easier to control. Acute and chronic effects of substance use may impact accurate assessment or danger. Substance use may impair her memory and thought process, and it can make safety planning more difficult. Under the influence, one may have increased sense of power and wrongly believe self-defense is possible, and substance use might cause a heightened response to threat. And obviously we all know that substance use also creates barriers to access support services. And when we work with victim survivors and discovering there are some of these coping strategies, and it's really important to avoid any victim blaming. The fact that she has developed these coping strategies and survival mechanisms speak of her strength. And as part of a therapeutic process, and when she's ready to do so, it might be useful to look at alternative, less harmful coping strategies. So if we move our focus to the perpetrator, we can recognize that some of these underlying perspectives feed into this. So again, he might use his own or the victim survivor's substance use in order to justify the violence. He might be blaming his own behaviour on being intoxicated, or blame it on being in withdrawal, or that he's not able to control his behaviour. Now, we all know that studies challenge this concept, that substance use is a primary cause of family violence, and it was demonstrated that perpetrators control in which way violence was inflicted, for example, in order to avoid leaving visible marks on the victim survivor. So nonetheless, this perception that can still be held by the perpetrator, and sometimes is a way he allows himself to excuse and justify his actions. And finally, when perpetrators use their partners or their own substance use as a mechanism to exercise further power and control, that's then what we refer to as substance use coercion. Now over to the poll for today.
Yeah, so we're just gonna put a poll up now for you. And we'd love it if you could take a second to participate in this. So the question that we're asking is, which of these is an example of substance use coercion, in your opinion? So you've got 4 options to choose from. So interfering with her treatment, undermining her credibility, blackmailing her about her use, or could it be all of the above? So we're just going to let you choose now, and I'm going to watch the results come up on my iPad. So, yeah, if you want to choose which one you think that is the correct answer, and then we'll go on to talk about it further. So far, everybody is, so far, number 4, all of the above. So we'll just give another couple of seconds to let people look in. I've got a few more people that are putting in some responses. Yep, so we might just stop the poll there. Thanks, Redback. Yeah, so actually interesting. So 100% of people who've participated in the poll believe that it is all of the above. Yeah, interesting. Oh, we did have a couple of people who just got it snuck in at the very last minute. So we actually ended up with 95% of people saying all of the above, and a couple of people have come in and said interfering with her treatment and blackmailing her about her use. So nobody's chosen undermining credibility. So most people have said all of the above. Yeah, which we would say is accurate. Yeah.
Okay, well, thank you for that. And it is indeed all of the above. So we found that substance use coercion can be very well illustrated with the Duluth power and control wheel, and particularly the version that we found that was adapted by Marie O'Neill from Illinois into a power and control model for women's substance abuse. So the pies in this wheel cover themes that has the potential to be a platform for substance use coercion. And I want to note that the pie using children has been removed in this version of the wheel, but the literature obviously agrees that any violence that is applicable for the victim survivor is also applicable for any children involved. So together with the multiple layers of stigma that Stephen referred to, using children as a power and control mechanism can double the impact of the threat. And it's not uncommon for the perpetrator to use children as a weapon against the victim survivor, which we'll recognise throughout the different themes. I will start talking about the wheel at the slice, encouraging drug dependence, as this is the most obvious form of substance use coercion. This can look different in a number of scenarios. For example, a perpetrator might introduce his partner to drugs, or he can encourage drug use and make it harder for her to reject the substances, or coerce her to use more and more in order to get her dependent on drugs and as such more in need of him. Another strategy used by perpetrators can be getting her high to enable her to sell sex. Alternatively, or in addition, he might control the quantity of drugs available to her, and he can then withdraw substances to induce a withdrawal or over-provide in order for her to overdose. Another very important strategy to be aware of is when the perpetrator might interfere with treatment. He might be her spokesperson and position himself as the supportive, heroic partner and carer of this crazy partner on drugs, and he might suggest couples therapy in order to remain control over the situation. He can also sabotage efforts to get support for drug use and attempts to address substance use. This may include having substances in the house when she is in recovery, forcing her to watch him use, forcing her to purchase and prepare the substances in the hope that she will relapse. So when we look at economic abuse in the context of substance use coercion, you might recognise scenarios that include the perpetrator taking her money, or he uses the family budget to buy drugs, leaving the victim survivors stranded and unable to provide maybe for the children. He might abuse her or threat to abuse her when she refuses or fails to raise money for drugs. He might also force her to engage in unsafe situations and illegal acts to source drugs. Here we can think of dealing or stealing or indeed sex work. Moving on to using threats and psychological abuse. Now, when we apply the lens of substance use coercion here, we might see some examples that he might threaten to hurt her if she uses drugs, or on the opposite, if she does not use drugs. He might blackmail her and threaten to tell family or friends, employers, police, child protection. One important example is when the perpetrator uses her fear of losing the children to child protection. Women have potentially already had encounters with child protection in the past and lost custody over children. So any threat to disclose her substance use to child protection will have a major impact. Another example can be when he coerces her into taking responsibilities for his crimes. When we continue to look at emotional abuse, some behaviours that would classify as a substance use coercion may include, for example, making her believe that she has a substance use issue and that she's addicted, but in reality she might not be. Or making her feel guilty for drug use, either in the past or in the present. He might make her think that she's crazy and not able to think straight, or that she's not able to make any choices for herself. He can, for example, humiliate her because of a drug use. And some examples here are that one victim survivor reported just after she got help for her drinking and she would drink again, that he actually said, "See, you failed at this too." And other reports include that the perpetrator might use a substance used to undermine the victim's survivor's credibility and indicate that because of substances, no one's going to believe her. So in this adaptation of the wheel, you can see that physical abuse is being brought back into the wheel. Both family violence as well as substance use have the potential for a lethal outcome because substance use has the potential for additional very specific abuse strategies. Risk of lethality, I can't say that word, lethality can be severely increased. Now, for example, physical abuse can be used as per the original wheel of power and control, which is inflicting or attempting to inflict physical injury, pushing, slapping, beating, choking, stabbing, shooting. But also important to note is that prescribed medications have the potential to be used as a means of control. So in particular, if we're thinking of pharmacotherapy, or pain management medication, or particular mental health prescribed medications, they might be of particular interest to the perpetrator. So he might steal her medication or take her medication for his own use. He might force her to sell them, etc. In different scenarios, substance use can play a more prominent role. Victim survivor might be coerced or forced into taking substances or more than she would like, or he might spike her drinks so she's not aware of consuming any of these substances. The perpetrator might control the preparation, and he might also, when we're talking about injecting drug use, he might first inject himself and then force her to use his used syringe. Okay, the next one talks about isolation. So again, bringing back those multiple layers of stigma increase the vulnerability of the victim survivor, and the perpetrator is in a position to use the stigma in order to isolate the victim survivor more and more. He can discredit her. He can be keeping her away from people that are supportive of recovery, being that from her informal or formal support system. So the informal support system classify as family and friends. He might inform them of current past use, or he might inform them of any criminal activities, or when she was involved in sex work. Disclosure to the formal network might include, again, the employer, police, etc. In one example, the victim survivor was afraid to actually call the police because her partner said that they wouldn't believe her because she was drug affected and that she would be indeed arrested. So in the list of minimizing and denying and blaming, I would also like to include the mutualizing and excusing of the violence. And again, here we can see how the different perspectives discussed earlier are the underlying drivers of this behaviour. We can think, for example, of the perpetrator might minimise her concerns about her own substance use, or deny her concerns about his substance use, or in fact he might blame her for his substance use. So the perpetrator might shift the responsibility for the violence onto her substance use. He might say things like, I'm doing this because you're an addict, or, well, you know, you're a drunk. He might deny her concerns about impact on any children that are in the house, or include the children in his strategy and state that he's trying to protect the children from her and say that she is a bad mother. He might also indicate that he's doing all this for her and that she's being very ungrateful, for example, if she doesn't want to take any of the substances he provides. Common perception is that when they say that they're both using the violence, and as such identify both as being a perpetrator or a victim survivor of family violence, and they might say, you know, violence is part of our relationship, this is how we roll. Last but not least, substance use has lent itself for a number of patterns of sexual violence as well. Available literature connected pressure to use substances with coerced sex. For example, a woman reported being coerced to use drugs because then the sex would be much better. Another example is when he forces her into sex work for drugs or drug money. Also, there are stories of marital rape or rape by acquaintances, and that includes after the victim survivor was passed out. Victim survivors have described scenarios in which it was common that sex was expected in exchange for drugs, and that violent sex was the expected norm. So there are multiple examples how that can play out. So now we start getting some insight in the different strategies used by the perpetrator. We can see that it might create a bit of a loop or a spiral in which the victim survivor can get caught. So firstly, we know through research that family violence and trauma from family violence, and in fact any other trauma, can have a significant impact on mental health and substance use. And perpetrators can use this to actively undermine their partner's sanity, sobriety, parenting and decision-making capacity. So on top of this, the perpetrator might control access to support systems and treatment, and he also may sabotage recovery attempts. So he can then use this to confirm that she's not capable, she's useless, and he may use all these concepts externally and undermine her credibility and access to support. And then again, this will increase trauma and increase risk. And we all know by now that judgment and discrimination will compound these risks. So I think it's really important to note that as treatment and service providers, we need to understand that some of these behaviours that victim survivors present with may actually be survival strategies and responses to ongoing danger and coercive control. So that adds a dimension to safety planning, as well as put a different light on some of the interventions we apply in AOD settings, including harm reduction, education, treatment engagement, assessing motivation for change, and also discuss relapse prevention. So we're going on to Paul 2 now. Are we not?
I'll just introduce myself first,
Yeah.
I think, Mariah. And I'm Susan George. I'm a specialist family violence advisor for the Northwestern and Southwest catchment and for all AOD services in those catchments, and auspiced by Odyssey House, Victoria. This section will follow on from what Steve and Mariah have spoken about, and will focus more on practice implications for AOD clinicians and focus on identification, questions and responses for victims survivors. Given that the focus is on victim survivors, there's an acknowledgement that women do use violence and use resistive violence. Women are also socialised, as well as men, to resolve conflict through violence. So you'll see as we go through, I have used some examples of questions that could be asked. And please note that it's not, these questions aren't prescriptive or to be used in any order at all. And what's most important to consider is that your questions are developed into response of what the victim survivor has already told you. Also, a lot of this information that I've taken from to inform the questions are taken from the research document Coercion Related to Mental Health and Substance Use in the context of intimate partner violence, a toolkit for screening, which is referred to by Steve earlier. And that research was done by Carol Warsaw and Erin Tinner. I'll hand over now for the second poll question.
Yes, let's do the second poll. Did you forget my name? So yes, we do have another poll, so we'll ask Redback to put the second poll up. And so the next one, what we would like to ask you is, what could you explore with a victim survivor to get an understanding of substance use coercion? We'll just wait for a second. Doesn't look like it's going to come up. I'm not sure. Yeah? Okay. We've got the thumbs up. It will come up now. So the question is going to be, what could you explore with a victim survivor to get an understanding of substance use coercion? So I suppose what we're asking here is to think about just some of the people that you work with, and what kinds of things might you explore to try and ascertain if there is substance use coercion at play with the person that you're trying to support. So the first option is you might explore what happens when they say no to their partner. You might explore how drugs are paid for, so you could ask questions around that. The third option is what has stopped them from seeking treatment before. So you might ask them some good open questions around that. And then option 4 is that you believe that all of these or any of these would be examples of things you might explore with your clients to ascertain if substance use coercion is present. So a few people are starting to respond already. Actually, it's interesting. Yeah, we've got a few people, first of all, have chosen the first response, what happens when you say no to your partner. Yeah, and I know that a lot of people who work as AOD clinicians do definitely hear that. They definitely hear, when you ask that hypothetical question, like, if your partner is injecting you, what would happen if you said to your partner that you want to inject yourself, or you want to take control of that? And that's always an interesting question. When you hear the responses to that, you can hear if that's actually an option for that person or not. So I do know that. I'm not surprised that one's come up. But now we've got, most people now are saying any of the above. We've got a few people saying what has stopped you from seeking treatment before, and that's really interesting because we definitely know that anybody that is in a relationship where parent control is present will definitely see that the partner will stop them seeking treatment, or they'll sabotage them in being able to get treatment. So we might stop that poll there. So yeah, most people have said any of the above, and just a couple of people said the first and the third response. So yeah, really, really interesting. Yeah. Thanks, Sue.
That's the wrong slide. What I wanted to, what I wanted to do is talking about the introduction to provide some information to clients that you're working with, and it's a good way to introduce the topic as well as asking questions. A lot of my presentation will be about questions that can be asked, but also in the beginning it's really useful to explain with an example of a statement such as, sometimes people who are being hurt by someone in their life and who have been hurt in the past use alcohol or other drugs to help them cope with getting through the day. This can include over-the-counter prescription medication and other kinds of drugs and substances. it can be important then to ask a question about, does this sound like something that's happening to you? And I think if you ask it in that way, you're actually allowing and notifying the person that it's okay to talk to you about instances like this. I don't know why it's doing that. So if the person responds no, it can be important to say to people like that it may, we may even need to ask this question again, and people may not be able to answer the question right away, and they may not feel safe to say this as well. As we'll see a bit later, there's many barriers to people, victim survivors, answering these questions. If they respond yes, you can use prompts for further explanation. And it's important to note that the victim survivor is not responsible for their patterns of coercive behaviours, but it may be useful to speak about how they resist the coercion whilst understanding it is not their responsibility to stop the violence. That's not within their power. The other things that you can ask is questions, if they say yes, is I want you to know that you're not alone, is offering a statement of support to them. Let's think together about what resources might be helpful to you, and do you have a sense of what might help you feel safer in this moment and after you leave today. It's really important to find out what's going to happen after they leave today in safety, because at the point of disclosure of violence, it can really heighten the threat of risk and harm to them. Most AOD assessment tools can be adapted to incorporate questions about substance use coercion, and I've used some examples here of general AOD questions with follow-up questions about substance use coercion and control. The AOD question can be, have you ever tried to cut down on your drinking or drug use? And then the coercion question can be, has your partner ever tried to stop you from cutting down? And then the AOD question, have you ever been annoyed by someone criticising your drinking or drug use? And the coercion question could be, have you ever been made to feel afraid by someone's criticising your drinking or drug use? And another question, has your partner used your drinking or drug use as a way of threatening you? An AOD question, have you ever felt guilty about your drinking or drug use? And the coercion question, have you ever felt coerced into drinking, using drugs, or engaging in illegal activities or other behaviours you weren't okay with? And that can be including sex work, and that other activities that you felt have compromised your integrity and then felt guilty about it. When the victim survivor has given an indication that there may be substance use coercion and family violence, here are some examples of questions you could ask. Again, it is important to be guided by what they have already said to you and really frame your questions around that. You can be asking about how does your partner treat you and respond when you are using, when you are sober or not using. Another question, does your partner use their substance use to justify their abuse? Is your partner only kind to you when you're using, but abusive and unsupportive when you are sober, or vice versa? What happens when you do not have any drugs in the house? And what does your partner do if you say no? Again, it's really important to be guided by what they have said to you already. Most AOD assessment tools, when asking questions about their substance use, it is important to consider what is affecting their use. So it's important to consider how or if their substance use might be related to living with fear, isolation, entrapment, experiencing economic control, physical violence, sexual coercion, being stalked, dealing with injury-related disability, which may be due to previous family violence, chronic pain, interpersonal betrayal, and training and trauma-related mental health symptoms. And example questions around this can be, I wonder how using more than you want to might be related to living in constant fear or being told you don't matter. Another question, I wonder how your struggle with overdose might be related to feeling trapped and seeing no other way out. And I'll use an example of a woman who would use overdose as a strategy to keep herself safe. As an ambulance would be called when she'd overdosed, and they would take her away to the safety of a hospital. And this was a way of her escaping from her violent partner, especially when she feared how she would be treated by police and that police could charge her with previous warrants or drug offences. Now that's a pretty extreme way for safety, but she'd worked that out as the best way for her. Other things that are important to consider is how their substance use might be related to living with fear. I think that's repeated. Okay, I'll move on to the next slide. I wanted to move on now to discussing about responding to disclosure. Knowing how to respond is critical for the victim survivor's safety and can make it easier to ask questions in a way that lets the survivors know that you're open to hearing and believe their experiences. Another really important aspect is to know that you're not on your own with this. So to seek secondary consultations from family violence services, your practice lead, supervisor and debriefing. It's really important to seek consultation. And also have an understanding that this is a collaborative process. With the new legislation and the introduction of MARAM, which is a family violence risk assessment tool, and it actually stands for Multi-Agency Risk Assessment and Management. So all agencies, including AOD agencies, will be required to use this family violence risk assessment. And also the utilising of family violence information sharing scheme and the child information sharing scheme. These are going to come into use more and more. Another important aspect is to really consider documentation and the importance of keeping the perpetrator in view and documenting patterns of coercion and control. Here are some additional considerations that may affect adversely and may adversely affect the victim survivor ability to engage in AOD treatment and disclose substance use coercion. A survivor may be reluctant to seek assistance or contact police out of fear of being arrested, deported, child protection involvement, children being removed from their care, losing a job or scholarship, being ostracised by family or community, or not being taken seriously due to their substance use. Keeping regular scheduled appointments can compromise a survivor's ability to avoid the perpetrator who may be stalking them, so an important consideration. Program expectations may require victim survivors to be not using in order to continue or access treatment, and this can seriously limit access to care and can be experienced by the victim survivors as punitive. When responding to victim survivors, it's important to have an understanding about the tactics that are often used. And I'm using a small example here, and I know Mariah and Steve have also referred to these in their presentations. Survivors might be reluctant to engage in treatment, knowing that the perpetrator might use this against them in their custody battle. Stigma associated with substance use problems makes it less likely that survivors will be believed or seen as capable of parenting. Perpetrators may accuse their partners of abandoning their children if they seek inpatient or residential treatment. And it also might not be safe to leave the children. So it's important to ask these questions. A question can be, are you concerned about the care of your children whilst you're in treatment? Also, another factor is interpersonal and structural homophobia, biphobia and transphobia can affect a person's ability to access affirming substance use treatment. The perpetrator may sabotage abstinence, recovery and her efforts to reduce use. So a question around that is, has your partner tried to stop you from accessing your treatment? from AOD treatment. A perpetrator might interfere with the survivor's ability to access prescribed medications. You can ask a question of, are you able to take your medications as prescribed? Leveraging substance use to get survivors to engage in behaviours that they don't want to engage in. And a question you can ask is, has your partner pressured you into sex work for drugs or also money to buy drugs? It's really important to consider, though, that actual sex works may be a protective behaviour as well. So important to ask questions about that in certainly a very non-judgmental way. Another important factor is often helpful to provide information that explains the tactics being used by the perpetrator, because people may not have heard, victim survivors may not have heard this before, and I've used some examples here. So you can use statements such as, your partner might find other people to agree that your substance use gives them the right to control you. This is a tactic to make you feel isolated and further their control over you. By undermining your credibility with other people, your partner makes it much more difficult for you to get support, be believed, and trust your own perceptions. Questions can be, does your partner put you down or make you feel stupid in front of others? I wonder how your fear of losing custody of your children is related to being told that you're a stupid or bad parent for using. It is never your fault when someone harms you if you are drinking or using, regardless of what your partner or society tells you. Your use does not justify violence against you on any level. You deserve to be treated with dignity and respect. And a question you can ask, have you been made to feel it's your fault when there is violence or substance use coercion? You mentioned that your partner regularly tries to get you to use when you don't want to, or to use more than you want to. You can ask a question, is there someone you could call if this is happening to you? Considerations about medication and treatment planning. These are important to consider. Certainly when considering harm reduction strategies, you need to do your assessment and strategies around the risk for substance use and also the risk for family violence safety planning. And often we're used to doing harm reduction, so it's important to do both. Relapse prevention strategies need to include coercive control and family violence, as this will be certainly an indicator and a risk factor of relapse. You can ask questions about how they think the perpetrator might respond to them in their treatment plan, and that can be asking, is there potential for the medication side effects to place you in a greater risk of harm, complications during transition to pharmacotherapy, including increased risk of withdrawal? Are there any concerns your partner stealing or using or selling your medications? Other considerations. When the style of relationship rotates around substance use and addiction becomes tied to the perpetrator, leaving the relationship can be interconnected with losing her supply of substances, especially if she is reliant on him for injecting her. This makes the decision to leave or end the relation much more complicated. Also, our own attitudes and expectations about substance use and sobriety can act as a barrier for victim survivors to engage with our services. Sobriety requirements versus harm reduction. Our attitudes are linked towards our risk assessment of family violence as well. In children, it's really important to consider children's safety and how that they are weaponised often against the victim survivor. I'm just going to briefly touch on safety planning because this has been done in the previous webinar, but it's important to consider how you might be able to maintain safety and meet with them again. It's important to listen to survivors' expertise and understanding of their safety. leaving or ending an abusive relationship and managing safety while they're being exposed to harm can lead to the victim survivor to relapse, use more than they want, or compromise their ability to safety plan. Discuss ways to reduce harm with AOD and increase safety, and there's some information there. And you can ask about if they know information about reverse opioid use. You can ask questions like, are there children at home? Ensure there's safety planning for children. Are there other services involved in children? We've discussed a little bit about MARAM and FIS before. When providing referral information and resources, consider how this can be done safely, because often it might not be safe for them to have this with them. Finally, I wanted to stress the importance of case notes and documentation. Often information about problems and difficulties about the survivor, the victim survivor, are expressed and recorded in the case notes, whereas information about the tactics and patterns of controlling behaviours, including substance use coercion by the perpetrator, are not recorded and certainly can be missing from the notes. And with the introduction of MARAM and the family violence legislation and the information sharing changes, it's important for keeping the perpetrator in view, and that this is done really importantly through the case notes. That finishes my section, and I'm going to hand back to Steve now.
Thanks, Sue. So just in summarising the webinar, substance use coercion is prevalent for those who seek treatment in AOD use. Narratives for perpetrators and victim survivors are different, and it's good to tune our radar to what those presentations are. Substance use coercion is, we've got the 4 points there: undermining sanity, sobriety, controlling medication, sabotaging recovery, and targeted, and importantly, targeted towards a partner's substance use. And also recognising potential barriers to disclosures are really important in the clinical setting. And then in Victoria again we have our MARAM risk assessment and FIS and SIS, which are there to increase safety through that collaboration and the shared understanding of family violence. And finishing up, here are our reference list with some pointers to some further reading, and also some resources that we referred to through the presentation. Thanks.
Thanks so much,
Sheridan.
everyone. Thank you. I know, and I apologise. I know that we were getting a little rushed there. We kind of knew that we would be rushed for time, so we apologise for that. If you do have questions, you want to pop those in. We just have a minute or so left. I have been responding to a few people as we've gone along, so thank you to the people who have popped questions in. There is one question from John, and I apologise if I'm not understanding your question correctly, John, but John's talking about, or asking about, there seems to be crossovers between victim survivors having risk assessment and then also their use of, alcohol and other drugs as coping strategies and survival mechanisms, and John's asking, is that a fair assessment? And I hope I'm understanding your question correctly, but yes, that's correct. So sometimes we will hear within the stories of the people that we work with that actually that alcohol and other drugs are being used as coping mechanisms, and a lot of times, they're actually things that keep them safe in a lot of ways as well. So it's up to us to ask those questions in a really nuanced way to really hear what's underneath and what's kind of going on alongside of the alcohol and other drug use for that person, so we can really critically analyse what's happening for them. But yes, a lot of times they're interrelated, and yes, I've definitely worked with a lot of victim survivors who definitely utilise alcohol and drugs to cope with what's happening in their lives. If you did have any more questions, you might want to pop those in now, but I think we might need to wrap up. We want to thank you so much for spending your time with us today. And those references that Stephen just made mention of, you have these slides to download. If you haven't done so yet, please download those and have a look through those resources. Please also stay with us to give us a little bit of feedback and give us some information about up and coming webinars that you'd like to see. And I do just want to plug my friend Rita Bryan's webinar. Rita is one of our colleagues. She's an education officer and she will be doing a webinar next week, next Tuesday, and it's almost fully booked to be live for this one, but there's a few spots left. Responding to new psychoactive substance use in the AOD sector. She runs a whole day training on this one, so she's just got a snapshot of this, and it's really, really interesting. So you can go to the Turning Point website and register for that one as well. So thank you so much for being with us today, and we look forward to seeing you again next time.